This year, over 100 million Americans will receive treatment from a physician who uses an artificial intelligence platform to help make clinical decisions. The problem is a matter of scale. Medical research volume is doubling every few years, while the time a doctor has for an individual patient remains fixed at roughly 15 minutes. OpenEvidence has emerged as the most widely used tool to manage this information. It is the first system to score a perfect 100% on the USMLE, the United States Medical Licensing Examination, and is now used daily by 40% of U.S. physicians. This adoption was accelerated by the platform's origins. It launched from the Mayo Clinic Platform Accelerate program, giving it immediate access to clinical authority. Manual literature review is no longer a practical option for the average clinician. However, shifting that search to an AI engine introduces systemic risks that remain invisible during patient care. General-purpose large language models have a documented safety issue in healthcare. They hallucinate. They often create medical citations that look authentic but do not actually exist. OpenEvidence addresses this through Retrieval Augmented Generation, or RAG. RAG is a technical framework that forces an AI to answer questions using only a specific set of documents, rather than its internal training data. The platform chains responses to a closed database of 35 million peer-reviewed publications, creating a secure boundary against unverified internet data. This includes a hard refusal mechanism. If the database lacks clear evidence for a query, the AI remains silent rather than speculate. Solving the hallucination problem introduces a different challenge. The platform replaces random fabrication with a more structured risk, algorithmic curation bias. Much of the world's clinical data is locked behind paywalls. Because these studies are not freely available, they are often inaccessible to standard AI web crawlers. To solve this, OpenEvidence partnered with major publishers, allowing the model to read the full text of JAMA and the New England Journal of Medicine. These partnerships can lead to journal bias. The algorithm may disproportionately prioritize research from high-impact partner journals over other credible sources. For a clinician, the danger is that niche guidelines or subspecialty research published in mid-tier journals might be buried by the algorithm in favor of more prestigious publications. Having access to the most famous journals does not always result in the most relevant answer for a specific, rare patient presentation. For the millions of medical papers where the AI lacks full text access, it relies on scraping 300-word abstracts. This creates abstract bias. It occurs when an AI bases its clinical recommendations on the condensed summary of a study rather than the full methodology. Abstracts frequently omit critical failures. Nuanced contradictions, like secondary endpoint failures or specific subgroup risks, are often left out of the summary. The AI then synthesizes these incomplete summaries into a polished, authoritative recommendation that hides the missing scientific nuance. High-speed AI synthesis can accidentally present complex, contradictory research as a series of oversimplified absolute facts. The technical risks are compounded by a physician's need for efficiency. A cited, formatted treatment plan delivered in seconds offers immediate psychological relief to a busy doctor. This makes users susceptible to LLM sycophancy. This is a mathematical tendency in AI models to generate responses that confirm and agree with the user's initial prompt. This feedback loop creates an echo chamber. The AI reinforces the doctor's original assumptions with cited evidence. The ultimate result is automation bias, where a clinician accepts an AI's output as truth without an independent critical review of the sources. While the AI isn't lying, its fluent delivery can persuade a doctor to delegate their clinical judgment to the machine. The platform is most effective at reducing administrative friction. It can draft prior authorization letters and retrieve frontline therapy guidelines in seconds, tasks that typically require hours of manual work. However, it is less reliable when synthesizing highly individualized patient cases involving multiple competing comorbidities. In the context of rare diseases, the model may report insufficient evidence because the relevant research lacks the algorithmic weight to surface in the search. Despite these edge case limitations, health leaders like Dr. Tom Frieden are deploying the tool to bring evidence-based medicine to under-resourced international settings. The safety and utility of OpenEvidence scale inversely with the complexity of the patient. To use medical AI safely, clinicians need a structured verification protocol. This workflow requires the doctor to evaluate the query, determine if the answer alters their diagnosis, and scrutinize the citations provided. The most important step is manual cross-referencing. The clinician must physically click the footnote to check the original research against the AI summary. This adds time back into the workflow, but it is the only way to catch errors caused by abstract bias or misinterpretation. A medical AI's utility rests on its transparency. Its primary function is to provide a direct, verifiable path from a clinical question to original research. Clinicians must choose between the slower certainty of traditional research methods and the high-speed, conditionally safe power of AI. OpenEvidence is a highly effective data retrieval system, but it is definitively not a replacement for human clinical reasoning. Regardless of the technology used, the legal and ethical responsibility for patient outcomes remains solely with the human physician. Artificial intelligence can successfully organize the world's medical evidence, but only a human clinician can weigh that data to practice medicine.